Assalamualaikum warahmatullahi wabarakatuh. We are from Group 9 and we will be presenting about the impacts of COVID-19 to oral health. We have 6 members in our group and they are NABILAH HUSNA, NADHIRAH YASMIN, SYAFIQAH HUSNA, AFIFAH SYAKIRAH, AISYAH, and also HASYA SHARIF. So now NABILAH HUSNA will be presenting about the definition and route of transmission of COVID-19.
I start first with the definition. COVID-19 is a disease caused by a new strain of coronavirus. CO stands for corona, VI stands for virus, and D stands for disease. Formerly, this disease was referred to as 2019 novel coronavirus or 2019 nCoV. The COVID-19 virus is a new virus linked to the same family of viruses as severe acute respiratory syndrome, SARS, and some types of common cold. Next is route of transmission. The virus is transmitted through direct contact with respiratory droplets of an infected person, which generated through coughing and sneezing. Individuals can also be infected from and touching surfaces contaminated with the virus and touching their face, example, eyes, nose, and mouth. The COVID-19 virus may survive on surfaces for several hours, but simple disinfectant can kill it. Next, I'll pass to my friends, SYAFIQAH HUSNA.
Assalamualaikum. So now I will present the predisposing factors. Firstly is stress. Stress is a common cause of health problems and your oral health is no exception. Stress may contribute to teeth grinding, gum disease, dry mouth, and canker sores, and may also impact your oral health routine and diet. As we all know, most of adults lost their job due to COVID-19, and this can lead to poverty. Thus, poverty also can lead to poor diet by increasing the risk of tooth decay. Next point is inability to seek timely dental treatment. Smoking habit, as people who smoke are at higher risk of developing oral cancer, gum problems, losing teeth, decay on the roots of the teeth, and complications after tooth removal and gum and oral surgery. And lastly is alcohol consumption.
So now I will be presenting about signs and symptoms. The most common symptoms of COVID-19 are fever, dry cough, and fatigue. The less common symptoms of COVID-19 are aches and pains, sore throat, diarrhea, conjunctivitis, headache, anosmia, ageusia, rash on the skin or discoloration of fingers or toes, and also asymptomatic. Some serious symptoms are difficulty breathing or shortness of breath, chest pain or pressure, loss of speech or movement. Then the symptoms related to oral health are xerostomia, which is dry mouth, ageusia, which is the loss of taste, anosmia, which is the loss of smell, oral ulceration, gingival breakdown, gingival hyperpigmentation, vesiculobullous lesion, aphthous ulcerative lesions, tongue depagulation, which is also called glossitis, and also commissural cheilitis. Now, the impacts on oral health will be presented by YASMIN, ILIAS, and AFIFAH SYAKIRAH.
I will continue with the impacts of COVID-19 on oral health. Next slide. The first impact is gingival inflammation. Bleeding and inflammation in oral tissues have been suggested to be a result of a generalized increase in inflammation due to elevated levels of cytokines and interleukins initiated by the SARS-CoV-2 virus. COVID-19 disease severity has been linked to immune dysregulation due to periodic disease, which increase the levels of circulating cytokines, particularly interleukin-6, leading to the cytokine storm. In the light of an urgent and effective surgical response, patients may experience acute respiratory distress syndrome as a result of acute lung damage accompanied by multi-organ failure and causing death. Therefore, cytokine storms must be managed as soon as possible. Next slide. Next is loss of taste and smell. A sudden onset in loss of taste and smell, or also known as ageusia and anosmia, are the two symptoms that can be the earliest indicator of COVID-19. An average of 47% and up to 80% of individuals who tested positive for COVID-19 can have subjective complaints of taste and smell loss, particularly in cases of asymptomatic or mild disease. The mechanism behind this loss is suspected to be direct viral entry into tongue cells because the tongue has an abundance of ACE2 receptors. In addition, in COVID-19 patients, ageusia and anosmia are not accompanied by nasal obstruction or other rhinitis symptoms. Therefore, this is probably due to the direct damage of the virus on the olfactory and gustatory receptors. Typical appearance involve lack or altered taste, burning, ulceration, inflammation, white or red patches of lesions, ichthya, and a whitish coating over the tongue. Next.
For the dysgeusia, it is the third most common impact of COVID-19 to oral health. 88.8% of COVID-19 patients suffer from taste disturbances, which is dysgeusia. This comprises of complete ageusia and partial hypogeusia, and generally we can call it as dysgeusia. So the first target for the SARS-CoV-2 would be the salivary gland. It will affect the angiotensin converting enzyme 2, which is ACE2. And there are also other mechanisms on how SARS-CoV-2 can affect our oral health and producing dysgeusia. The first one would be the neurologic nature, for example, such as impairment of olfactory system. The second one is the disruption of inflammatory response pathway. And the third one would be tissue hypoxia or injury. So the fourth impact of COVID-19 to oral health is xerostomia. Xerostomia is a condition of dry mouth. It is shown early in 60% of COVID-19 cases and can also resolve, depends on the severity of the condition. The virus will penetrate through the angiotensin converting enzyme 2, ACE2, which usually present in salivary gland, tongue, and oral epithelium. The virus will then infect and cause saliva alterations and then will cause xerostomia. Next. So the last impact would be oral ulcerations and gingival breakdown, which is a kind of vascular abnormalities. The virus will enter the endothelial cells via ACE2 and will cause oxygen deprivation and can also increase the inflammation, which will lead to ulceration and also tissue injury. There are three common sites of lesions, which are tongue, labial mucosa, palate. And also the prevalence for the oral ulcerations and gingival breakdown to occur is also equal in both genders. Next, I will pass the floor to NABILAH HUSNA.
Next, I will proceed with the risk of infections to dental workers. It can be exposed via face-to-face communication, exposure to saliva, blood and body fluid, and handling sharp instruments. The risk is based on two factors. First, exposure. It is how frequent a worker is exposed to disease. Dental procedure involve high aerosol formation from motorized dental instruments, such as scaling and filling procedures. And the second one is proximity, which is physical distance when at work. No possible social distancing between patient and dental practitioner. And the dental treatment is usually confined in a small room. Next, I'll pass to SYAFIQAH for case study.
For the case study, I will read the important points that we get from the statement. Firstly is the age, which is 43-year-old woman that tested positive for COVID-19. Secondly is the symptoms, which are fever, malaise, dysgeusia, and anosmia, diarrhea, and pneumonia. And there is also a risk of thrombosis. In the last 2 weeks, she reported abscess-like lesion, burning sensation, and tongue depalpation. After treatment, lingual depopulation persisted, but ulcers and burning sensation disappeared. As you can see at the image, bilateral atrophy of the surface of the tongue located in the lateral sides. Lateral dorsum appears depopulated with a symmetrical distribution.
Next will be presented by Aisyah.
I will be presented about the prevention of COVID-19 to the public in daily life, also to dental practitioners. So we go to the public first. Firstly is we need to maintain social distancing, at least 1 meter distance between ourselves and others to reduce the risk of infection. Second is we need to wear a mask and make wearing a mask a normal part of being around people. Make sure it covers our nose, mouth, and chin. Thirdly is we need to practice basic hygiene such as regularly and thoroughly clean our hands with alcohol-based hand rub or wash them with soap and water. We also need to avoid touching our eyes, nose, and mouths. We need to cover our mouths and nose with our elbow or tissue when we cough or sneeze. Then the used tissue need to be disposed immediately into a closed bin and wash our hands. The last step of prevention is avoid the 3 Cs, which are the space that are close, crowded, or involve close contacts. Being in crowds like in restaurants, bars, fitness centers, of movie theaters put us in higher risk for COVID-19. So we need to avoid indoor spaces that do not offer fresh air because these environments are where the virus appears to spread by respiratory droplets or aerosols more efficiently. Moving on to the prevention for dental practitioner. As we can see, the pyramid here shows the hierarchy of controls for COVID-19. The standard protective measures in daily clinical work are not effective enough to prevent the spread of SARS-CoV-2, especially when the dental patients have no symptoms of COVID-19 or they are unaware if they are infected or choose to conceal their infection. So the first step is elimination. Malaysian Dental Council has advised to postpone all elective dental procedures during this COVID-19 pandemic, except for emergency dental treatment. The next one is substitution, but it is not applicable in this situation. So we moving on to the engineering controls. When emergency dental care is needed, we use engineering controls to shield dentistry workers, patients, and also the visitors from exposure to SARS-CoV-2. This includes placing barriers between patient treatment areas, or the dentist can use high evacuation suction, dental dams, and other methods to minimize the aerosolization of droplets. And then administrative control, we can complete a health screening assessment for the patients to determine whether the patient should be considered suspected or confirmed COVID-19. And the last but not least is to apply safe work practice. We can wear appropriate PPE, which is also being called personal protective equipment. Next slide. So this is a picture of appropriate PPE that consists of a few things like surgical cap, Google, and etc. This is just a picture of dentists that giving treatment to the patients with a full PPE in order to minimize the risk of infection from the patient. That's all from us. I hope that this COVID-19 will get over soon so we can have our normal life. And thank you.